So hello everyone and welcome to this webinar on optimizing healthcare workforce, and we are going to focus basically on the workforce and resources and how to optimize the resources, how to optimize the resource allocation so that within limited resources, specifically in the context of LMICs and rural health, how we can optimize the delivery. This is the main agenda of this topic, and here it's a much more an open, more of casual discussion. We'll take your views, suggestions that will help us to build a very good manuscript, a position paper on this topic. And before we begin the discussion, I would like to welcome you all, and we'll just begin with a round of quick introduction, and I'll begin with myself. I am Pratyush Kumar, Chair-elect of Rural Wonka, which is Wonka Working Party in Rural Practice, and the Chair of Wonka Rural South Asia, and the convener of the Global Rural Health Summit. Next, Jill Conkin, please go ahead. Welcome.
Yes, good morning. I'm Jill Conkin. I'm at the University of Alberta in Edmonton, Alberta, Canada. I'm professor of family medicine and very involved in rural medical education and rural medicine.
Thank you. Paul?
Hi, I'm a rural practitioner in the state of Colorado in the US, also associated with the University of Colorado as a rural preceptor. And then I spend a fair amount of time every year in Central Asia for the past 30 years, helping with primary care development, especially family medicine and primary care nursing.
Thank you. Paula?
I'm in Peru. I'm a MD. I'm a epidemiologist. I work with indigenous communities in the Amazon, and I deliver healthcare and also adaptive culturally. Thank you.
Thank you. Vikas Goshen, can you hear us?
Yeah. Hello, everyone. My name is Vikas Goshen. I'm a family doctor from Nepal. I'm currently working as Wonka South Asia Regional Treasurer.
Thank you.
Good to meet you all.
Gobit? Okay, Gajanan?
Gobit here. I'm GP from Sri Lanka, also the part of the Wonga Rural. So happy to be here. Thank you.
Thank you. Gajanan?
Hello, I'm Gajanan. I'm from Chhattisgarh, Bilaspur. So I work at organization Jan Swasth Sahyog, and I'm a family physician. Thank you.
Thank you. Dr. Anshu?
Hello, everybody. I'm a pathologist from the Mahatma Gandhi Institute of Medical Sciences, which is a rural medical college in central India. I'm here representing the Network Towards Unity of Health. I'm on the board of directors there. Thank you.
Thank you. Izaz Khan?
Hi, I'm Ijaz Khan. I'm professor of public health at the Health Service Academy, Pakistan.
Thank you. Yukti? Yukti Bhandari and...
Hi, good evening, everyone. I'm Dr. Yukti Bhandari. I'm a senior resident in the Department of Community Medicine and School of Public Health, a postgraduate institute of medical education and research in Chandigarh. It's the institute of national importance in northern India.
Great. Mayur?
Hello everyone, I'm Mayur from Mahatma Gandhi Institute of Medical Sciences. I'm currently a final year resident in the Department of Community Medicine.
Great, welcome. Areraj Das?
Good evening, everyone. I'm Dr. Areraj. I'm a senior resident in Community Medicine School of Public Health in PGI Chandigarh.
Okay. Martha Agbedo? Paula Torres?
I am Dr. Martha, a resident in family medicine at Late of Apostles Hospital, Ibadan, Nigeria.
Okay, thank you. Devanto?
Hi, I'm Devanto. family physician in rural Indonesia. I'm also a member of Wonka Working Party for Mental Health with Prof. Christos. Maybe he hasn't attended yet. I'm currently also helping in writing the manuscript in Versa. Thank you.
Thank you. Thank you. We have got many other members who will join in a couple of minutes, but I'd like to start this discussion by inviting Vikas Gauchan, who can just brief us regarding the topic. And if you can just give an introductory remark on this topic, because you are drafting the manuscript. Vikas? Vikas Gauchan?
Yeah, just a minute. Thank you, Pratyush. Thank you, everyone, for joining us today. Today is very important day, and I think in just 5 weeks we're going to have very wonderful time talking about this very important theme, which is optimizing healthcare delivery. How what can be the workforce strategies? So basically, we have Christina, and then we have Mandisa, we have Solares, Paulina, we have Jill Konda, and Christos Leonis. They want to Christina, and then they want to Muna, Yukti Vandari, and Ari Trick. So we let me share my slide. Let me share the draft. Pratyush, can I share? Who's
Yeah,
this?
you can share.
The sharing option is disabled.
I have made you co-host. Now you can share.
Okay, thank you. So here is the draft. We are working online, Google Doc. So it is in this latest form. So we have this brief description, and we have all the authors contributing to this concept paper. I hope this will be converted into manuscript form in very soon. So we have Christina working on abstract, Mandisa working on
I
introduction.
think you have not yet shared the. It is not visible from.
Is it visible?
I don't think so.
No, it's not.
It's not. Oh. Can you see now?
No.
Oh, what's happening?
No issues. You can just give a brief overview. We can come back again
Sure.
and.
Sure. So what we are trying to do is we're trying to focus on innovative recruitment techniques, and we are trying to focus on recruitment and resource strategies, effective retention strategies and strategies, staffing models, financial infrastructure investment, innovative approach if there are any, public and private partnerships models if there are any, and role of policy in healthcare optimization, and digital literacy as well. We are working on this, and then we are going to also share some of the examples. um, mm, um, I have drafted a few examples from Nepal. In Nepal, many vertical clinical programs like antiretroviral therapy, drug-resistant tuberculosis, as part of the DOTS program. They are basically overseen by mid-level healthcare workers. They are supervised regularly, but majority of the clinical services are delivered by mid-level healthcare workers. In some hospitals, mental health care, the primary mental health care is provided by mid-level healthcare workers. Emergency obstetric, and some forms of orthopedic services are delivered by GPs. So these are the examples we are going to write in our manuscript, and then we will be providing innovative recruitment techniques, as well as recruitment retention strategies. What would be the retention strategies in rural and rural areas, basically, and financial model as well. This is where we are now. We have started drafting the manuscript as well. So hopefully in the next 1 or 2 weeks, we'll be making it more robust, I think.
Okay. We'll take views from the panel, those who have joined us. Jill, come back to you. And what's your views on the workforce which you work in? And what are the strategies which you have seen, which have worked in recruitment and also in the retention of the workforce, especially in the rural areas, in your context?
Sorry, did you ask me, Pratyush?
Yeah, yes, I asked you.
So I mean, there are a number of things that people try. One of the key things has been to, at least what's happening here in the province that I'm in, is to expand team-based care. And as was stated, that some of the healthcare can be delivered by others besides physicians. And our rural health force is primarily family physicians at this point. So expanding team-based care, and also in our country, medical students tend to be older because they have to have a degree before they go into medical school. And so commonly we'll already have partners, spouses, families, whatever. And one of the recruitment things that's necessary is you have to recruit the family, in particular the partner, as much as you do the practitioner. So I'll stop there. There's lots of other things, but I'm sure other people have good ideas.
And do you believe that these team-based care is always led by a family doctor, or it's mostly it could be anyone? It could be either nurse-led, or it could be anyone, a health manager-led.
It's to this point, the attempt is to have it led by a family doctor, and not that the family doctor's in charge, but that they're ultimately, how shall I put it, they're involved with the patients. But the other health professionals can come to the family doctor if they need help, and if they don't, they just carry on. But there's a backstop for other health professionals.
Paul, what do you see in your areas? What are the strategies which you have seen working in your context?
Well, let me focus on our work in Central Asia. We mainly work in Kyrgyzstan, and I have been there for about 30 years on and off. The things that have worked the best over the last 5 years, number one is the Ministry of Health began requiring that family medicine residents who had had their medical school paid for by the state had to do a rural residency. And they tried to place people in their home areas. And that made a big difference. The first 20 years of family medicine in Kyrgyzstan, there were about 500 residents that were trained, and a tiny, tiny fraction left the capital city. But after they made this change of requiring rural residencies in family medicine, there are quite a few more, at least 30 residency graduates that have now stayed out in rural areas. And this is a small country of about 7 million people. So that's worked well. They do have some financial incentives with bonuses for staying 3 years. They still have very low salaries, but they're going up. And that's one area they need to really improve in. So
And
I think
do
those are
you
the
also
things.
train these students, the residents in the rural areas, or are they trained in the urban areas and then they are brought back to rural areas?
No, they go immediately after they finish their medical school to the rural areas. So there are some problems with that, but overall it's worked much better. They actually get much more clinical experience in the rural areas because in the capital city, they tend to be one of 10 residents watching and attending, take care of somebody in a hospital. And then in the rural areas, they're in charge of a population of 2,000 to 5,000 patients usually, and get a lot of experience. They have less than ideal supervision. And that's one of the things we've been cooperating with the various medical institutes in Kyrgyzstan to help train rural preceptors. But overall, I think the pluses have outweighed the minuses, and they're making some good progress there.
We'll take back opinion from Paola. What's happening in your area and what's your experience with the recruitment and retention of the healthcare workforce in general? Not only family doctors, but nurses and mid-level health workers.
In Peru, here is something similar. You train the doctors for the cities basically, and then they have they immediately graduate and they go to do a 1 year rural service. So they have more practice according to this area, but then they immediately go back to the cities to do a further specialization. So in rural areas, you're for a year with this physician, that they are supported by nurses, health technicians, and the local communities, no? So once they come back, the ones that do basically, for example, dogs has been a very good service with the nurses, okay? And the other things in the communities, they are left with health technicians. Problems to retain people over there is we don't have money, they are not well paid, and the remote areas are basically lack of infrastructure, basically. Yeah.
Okay. And the training happens mostly in the urban areas or in the rural areas?
Yes, the universities, the main universities are in cities, basically. So the rural experience is very little through the medical training. I'm based in a university which I try to teach rural things. And not all are interested along the career. They become interested once they finish because they have to go to the ground, no? That's the main problem, yeah.
Okay. We'll take another viewpoint from Indian context. Yukti Bhandari, are you there?
Yes.
Yeah, Yukti. So can you please give an overview from our Indian perspective, Indian context, that how the recruitment and retention works in rural areas and regarding the training which happens and how this is currently working?
So I've been majorly working in the government sector. So in government sectors, we have two kinds of positions. One is your contractual position, one is the regular one. So with the contractual positions, you get like contracts for 1 year, 2 year, maximum of 3 years. And that is one of the challenges where we face that not many people want to settle down in rural areas. Everybody wants to rush to the cities, have a better quality of life, better standard of living, better access to health. So in terms of our contractual staff, we have a very high turnover. We have a very high attrition rate as well there. But in terms of a regular staff, because they are paid a stable income and they know their job is not going anywhere, the job is safe, they tend to settle down in nearby areas. And with the permanent staff giving them job security, it really helps with the retention of staff. And similarly goes for the doctors as well. As soon as they find a better paying job or a more comfortable home, they tend to move to the cities and tend to find a more stable job than settling down in rural areas. So those are a few challenges that we are facing in the Indian setup, that rural areas lack a lot of amenities, which after studying for 10 years, 12 years, doctors don't want to compromise on.
Okay. Do you believe that training of medical students in urban areas versus rural areas, there could be some changes in the retention of healthcare workforce? Like if the medical students are more trained in the rural areas, then there are more chances of their retention and continue to work in the rural areas.
Like from a very personal perspective, I would say that it would not help in keeping them in the rural areas. It might help providing some services in the rural area by the during the duration they are, studying there. So that is what there are a few initiatives being taken in those areas where we are trying to have some rural postings, giving some rural trainings, trying to open up more medical colleges in rural areas so that we have some workforce in those rural areas. Opening up medical colleges in rural areas does help to a certain extent because then you will have faculties, you will have doctors available in the hospital where the medical college is being opened. But still, it is a basic trend that people would rush off to the cities rather than staying in a new medical colleges because of limited scope of having development around the medical college.
Okay, thank you. Dr. Anshu, your views on this?
I'd like to specifically talk about the medical students that you were asking about, and our experience with Mahatma Gandhi Institute of Medical Sciences in Sevagram. What we have is a community immersion experience, which starts from year one, where every batch of students adopts a village, and each student has to adopt and follow up at least 3 to 4 families in that village. So what they do is to do their entire learning in the community on those patients. So 1 week it is nutrition, 1 week it is hygiene or sanitation, and we start off with like a bolus dose where we have a camp of 15 days where students stay in the village and communicate with the villagers. But throughout their 4.5 year course, every month they are taken to the village on one Saturday where they learn a different topic. So this kind of exposure, which we call an immersion experience, is something which tells them about the real life in the villages. Most of them who come from urban areas, it comes like a culture shock to them when they first actually go to the villages. But this experience helps them to learn how to prescribe cost effectively, how to understand the nuances of culture, the cultural humility that you talk about. So these are things which really help. Um, and they also interact with the local healthcare worker. So these are things which help them avoid the usual trap of medical colleges situated in the urban areas where they are taught in the uh, four walls of a tertiary care center, and when they go to the rural areas they feel frustrated because they know what to do but they're not able to do it. So that kind of learned help is something that they all face. And you're lucky to have Dr. Chabda in this group here. She's a former dean and a very uh, seasoned obstetrician. So I think she can give her inputs on how this works and also how the midwives can help in obstetrics care. Thank
Sure.
you.
Champaran, can you hear us? Hello.
Ma'am, we are not able to hear you.
No issue. We'll go to Aitrick Dash for the time being, and we'll take his views regarding the resource allocation compared to rural and urban, and what could be the strategies which could help us to bridge those gaps in terms of various kind of resources. Aitrick?
Yeah. Good evening. So, in terms of resource allocation, if we want to talk about again from a workforce point of view, because ultimately we're talking about the workforce strategies. So, for example, like even in the previous question that we were dealing with, several states in India are trying the rural uh, postings, like bond postings. Like after you are done with your post graduation, you are given a 1 year, 2 year, 3 year posting in the rural areas, in the suburbs or in the actual village areas. So, or in the sub district hospitals and so on. So that sort of allocation, if done uh, like in a manner that is rational. For example, you send a pediatrician to a pediatrician's posting, you send a dermatologist to a dermatological posting. That sort of allocation, if done properly, then it incentivizes the doctor to not only just go and practice in the hospital, but also to set up their own practice in the surrounding area. So that could be a community medicine, family medicine doctor. It could also be any physician, it could be a medicine or a ENT, whoever. But they set up a practice, private practice for the duration of the 3 years, 2 years in that area as well, which sort of makes the healthcare more accessible, uh, reduces the travel distances, reduces all other sorts of logistical problems, and also brings a lot of uh, medics, the pharmacy, brings up a lot of pharmacies or medicine, the economy to the place rather than uh, the people having to go somewhere, the villagers having to go somewhere else to get the entire gamut of services. So that could be like that is one strategy that is being used in several states like
Uh,
West Bengal, Maharashtra,
okay.
etc. to deal with.
I'll just ask you one question, right? Don't you think that these compulsory bond postings, like compulsory sending students to rural areas to serve a particular 1 year or 2 years, won't it cause some kind of repulsion or won't it affect the quality of service?
So, in terms of quality of service, again, like it can't be the only intervention. Like we are talking about introducing students to the rural form of, family adoption programs and so on from an early stage. So obviously we are easing them into the entire process, but uh, we need to stop looking at the rural postings as a form of block to the career progression. We need to make that work. So for example, I can speak from experience in terms of West Bengal, where there was an entire system of serving in sub-district hospitals and other rural areas after your MBBS, and that makes you an in-service candidate, which gives you a certain sort of different preference in terms of your residency later on, when you're opting for residencies later on. So that sort of incentivizes even after your MD. I believe that a 3-year bond posting, especially for people who are looking to stay within the state, it actually helps them establish a practice, an area, an area of practice other than the town or city they would like to settle in. And it actually probably helps them, which they don't realize maybe early on, but once they start, they actually do get into that. Like, that's what I've seen from my sort of anecdotal experience of the people around me, that they've all got into that sort of rural practice as well as the city practice, just because they've been posted in that place. So I think that's a model that we should not completely, exclude at the time.
Right, right. I think this is a very good suggestions. Like immersive training and with well-defined the career pathway, the rural pathway will help health professionals, not only the family doctors but also nurses and other health professionals to work in rural areas. Dr. Anshu, please go ahead.
Yeah, I'd just like to add to what Arithrik just said, and I agree with him that rural postings are not to be considered as punishments. So we used to have something like called the rural placement scheme in Sevagram, which unfortunately now because the NEET has come in, they've stopped it. The courts have not allowed us to go it. So what we used to do is that we had a collaboration with around 100 non-government organizations throughout the country, in rural areas. And we chose those centers because they had good supervision. So, what a student needs is good supervision where they're not scared to work in a place whereas they're scared to go wrong. So, as long as they had good supervision and the students were paid well, it was a win-win situation for both of us because our students got training and the NGOs got doctors every year regularly. So that really worked. And the third incentive for that was if you finished 2 years of rural posting, you got a postgraduate seat automatically. So that
Okay.
has been removed now by the government of India because of the entrance examination. But that was a scheme which really worked well for us.
Okay.
Thank you.
And anyone else who would like to talk, they can just raise their hands on there's an option on the Zoom account. They can raise their hands and I'll get back to you. Paul, please go ahead.
Oh, sure. Yeah, one of the biggest factors for satisfaction and retention in Kyrgyzstan is for residents to be placed in their home village or town. Most of the residents are married women, and many have young children. So having built-in babysitters next door has made a big difference, and they much prefer being in their home village rather than in the big city where life is difficult and babysitters are scarce. So
I think in India we have got the policy that they can recruit you to any place but to your home district. That's the uniform policy everywhere there in India, I guess.
oh, just the opposite.
They won't post you in your home district. They can give you adjoining district for the postings, but they won't give you the home district. I think the home district, they keep it reserved for your last few months before retirement. They give you that posting as a home district, but before that they have to serve outside their home district.
Oh yeah, it's worked just the opposite in Kyrgyzstan. That's been really successful.
And it has worked very well in Kyrgyzstan. That's very good. Azaz Khan, can you please tell us something regarding Pakistan, that how the workforce recruitment is working there?
Yeah, thank you very much. I was listening very closely, and the model that was told about placing the students in the rural areas in which they have the families, and that's an excellent kind of thing. We don't have it in Pakistan. And I was thinking that why shouldn't we try it here as well? Because I did my master's from Thailand, and there in primary health care, what they do send students for 2 weeks in the rural areas where they live with the families and they go through all the process in their health centers, and this they also do for the master students. So in Pakistan, actually we also have this problem where the medical students, they look to do USMLE and PLABs and all those and just fly out. So that's a big problem. And then we have private medical colleges along with the public sector medical colleges. And within the past decade or so, these private medical colleges, they have come up just like mushrooms, and they are producing a lot of medical graduates, and all of them, when they are paying so much money out of their parents' pockets, then they just either they go, then they of course they just land in the other countries. So we still have a lot of shortage of doctors. We have a lot of shortage of nurses and paramedics. So we have a kind of a huge issue of human resource for health. One thing is this, that this is not well planned. It's not well, like the data is not backing how much human resource that you need in the health sector. And I think in my view, when this chapter is being written, the South Asian countries, first question is this: what is their present disease burden, and how it's going to be looked after 50 years, or 30 years, or 50 years, and how the countries should be planning for their human resource. Because if the diseases, the most of the countries, the South Asian countries, which used to be low income countries, now they are becoming the emerging economies. Like India, it's going to be the third largest economy of the world. So in Pakistan as well, the burden of malnutrition is shifting towards obesity now. And also we have more and more NCDs and mental health issues, and same goes for the other countries. So this shift also demands for uh, a very kind of basic thinking, how should we think for our future human resource. The same problem that the healthcare workers, especially the doctors, they shy away from the rural areas. They don't want to go to the rural areas. They want to stay in the tertiary care hospitals, do their post graduations and all those things. So there is no concept of doing specialization or in the primary healthcare, working in the rural setups, because we still in Pakistan, we need to have bring in the GPs into the circle in which the government hires them for the primary care. and a lot of training. And we are doing now. We have started up with diplomas and all a lot of trainings in the primary healthcare in Pakistan. It's very slowly. It is evolving, but very slowly. So
Okay, so
there is a need to set direction.
okay,
That's what I
in your opinion, like what could be the strategies to retain more health workforce in rural areas? Like what incentives could be given to attract more doctors, nurses, other health workforce in rural areas?
Yeah, I think because you see, our medical curriculum is geared towards the clinical side. It's not towards the preventive side, or it's not towards the how to decrease the burden of the diseases through, for instance, through the lifestyle changes. So a medical student loses his interest when he or she starts studying community medicine, typical community medicine topics in the fourth year of MBBS. So and they look at their teachers who are surgeons and medical specialists, and they have the super specialty. So they have their role models in front of them, but none of the role model is there, which is working in the rural areas. So what I think that apart from any kind of you can say the financial incentive, there should be some role model incentive as well, and there should be also a mind shift change. I have been to Iran 7 years ago, and I spent 3 weeks there studying their primary healthcare system. And what I found that newly graduate from Tehran University of Medical Sciences, she was heading a rural health center kind of a facility in a rural area of Iran, and she was being paid a pay which was perhaps equal to the professor of Tums. But she had a very different kind of. But she had not on it just was not her responsibilities included even the checking the milk in the houses as well, and water quality, all those things which are. That's a holistic approach. If you are paying, if you want to retain a healthcare worker, whether it's a nurse or a lady health worker or lady health visitor or a healthcare or a doctor, if you are paying them at par with and you want to retain them, then I think their responsibilities should also not be just to do the day-to-day patient management or doing the OPD or something like this. They should also be doing all those things which are required to do the primordial prevention along with the primary prevention. So those should be their responsibilities, and once they are there, then the indicators should be monitored, and then those should be communicated to them as well.
Gobit, just tell us something about Sri Lanka. That what's the recruitment strategies?
Yeah.
What is work there in Sri Lanka?
Yeah, I think this is Sri Lanka also similar to India, but still that the Sri Lanka is a small island country, and more than 80% are living in a rural area. So in the same time, we have the very great network of primary healthcare centers in the all part of this island. But about this placement and retention of staff, actually, we have categorized even for the medical doctor. So like in other country in India, and so we are posting after post intern to the according the placement list. So anyone has to go according their merit number and all. So almost 90% are they retained there in the area, but few are actually leaving. So, but anyway, we managed to put some medical doctor there in the even rural area. But mostly that's issue is that's a mostly in one man station. So they may have difficult to find the other facilities and even the leaves and all things. But other than that, about the other health staff, including nurses and all, that's a bit a tricky one because who are from the native place only they retain there in the area. Otherwise, they will go and they will feel because most of the nurses also may will female officers, so they may come for the family life, so they may leave with that. So that's has somewhat compared to the medical doctor and other staff. but that's somewhat covered by the community health workers in the villages and all. But as you are talk about this how to improve this about that, actually last 10 years we have started the rural curriculum in the medical school. Almost all the faculties have, and they also exposed there, so that had a simple impact on there, because if they go there they will know that, so this not that, because otherwise they will think this is a very hard to live or hard to survive in their area. So that's some has impact. Other than that, actually the government has to take a more initiative, like the giving some incentive and something, even though giving the basic facilities. So if you go there, at least they should have some accommodation facilities and that sort. And more than that, actually we are having the more issue, because most of the staffs are migrating to other countries because of the low salary in the region like that. So we are still struggling, but the wise we managing the way. So actually there's no incentive at all, but other than the small allowances, very small one. So that's the situation in Sri Lanka at the moment. Yeah.
Okay. We'll take views from Devendra from Indonesia, that what's happening in their country, and what do he see as the recruitment strategies, what's worked there. Devendra?
Yeah. So everyone else have already given their opinion. So Indonesia also faces the same problem as in Pakistan, in India, and in Sri Lanka. So same problem, just different name. In essence, in Indonesia has implemented various programs to access the shortage of the medical staff in rural areas, such as the mandatory 1 year program internship in the rural area after their MD certification. And then there's also the optional PTT program, which is a high financial incentive run by the local government to attract doctors to come and work in the rural areas. And also they are given recommendation letters by their regions or government to go to specialize and then return to the local areas. But so far, it has not proved any result. And then there's also the mandatory 1 year after their specialized program is done, then they will have to go back to the rural areas to practice there. And then afterwards they just go back to the city, just because of the good life in the city. They just don't want to stay in the rural areas. But so the ongoing efforts are still needed to improve retention rates in the country, not only financial incentive, because so far, even though they are given a lot of money to stay there, but we also still maybe need to improve the working conditions. They are given working space that are maybe not on par with the ones in the city. Also, there are less career development opportunities there, less continuing medical educations, and also maybe foster a supportive environment for the medical staff over there, because same in Sri Lanka, maybe they just one-man army over there, only one nurse or a midwife that can help them. So far, nurses and midwife is one of the good points in Indonesia. There are pretty much available everywhere, even in the rural areas. Mostly the nurse or the midwives are also the locals over there. So they are the ones who stay in the area, and while the doctors are come and go. Okay, that's all for me. Thank you.
Thank you. Martha Agbedo, or Paola, if you would like to talk regarding the strategies which could work, which have worked, or do you know any models which has worked in your area?
With vision of many experiences similar as you've been told, and as I mentioned in earlier, the students go with little training over to the rural areas, no? And they want to come back. So basically, the thing that they don't allow to stay is because they feel it's not prestigious. So if you put something with this training that gives them some sort of training and prestige plus a basic salary, that would be a good strategy. Yeah.
Okay, incentivizing the workforce to work in rural areas. Sufyan, can you hear us? Sufyan or Martha, anyone would like to talk? I will go to I recently saw there's one comment from Pramod Roy regarding the older doctors who have retired. Would you like to talk, Pramod Roy? He's given a very nice comments that the older doctors which we have retired, they would love to work in rural areas because of some kind of philanthropic feeling. That's a nice comment. And Jill, you have made a comment regarding the structural urbanism. Can you just talk something more on the structural urbanism and how it's affecting the rural recruitment?
Yeah, I would commend people to read that article, though it is very US centric and North American. But there's another article that I would recommend people if you haven't already seen it, but I know she spoke at the last Rural Wonka conference, and that's Malin Moore's Geographical Marxism. So when one looks at health systems, they're almost always run by urban people, even for rural. And the way money is parceled out is based on what works in urban, but doesn't work in rural. And that's where they coined the phrase structural urbanism. That and so I mean, I find finding these kinds of theoretical, well, Probst isn't just theoretical, it's got examples. But the idea is that we keep trying to make something work when structurally it's working against us and will continue to work against us as rural professionals. And so some of those things need then to be tackled. So I would argue then that the whole way rural health is funded, and that would be no different in any country, though obviously in North America we have more money, though we've got governments who are beggaring our health systems these days. However, I think that we have to look at some of those systems problems, because no matter how much rural experience we get for our students, no matter how many rural students we take into medical schools and nursing schools and whatever, we're still working against a system that works against us.
Okay. So now I'll take some final comments on the possible solutions which you can propose regarding this disparity between rural urban, whether it be resource allocation or the health workforce, recruitment and retention. What could be the possible solution? Just you can give 1 or 2 points, the bullet points, and I'll just start with Paul. You just go with your possible solutions which you can suggest.
I've spoken about a number of them. Another one they use in Kyrgyzstan is that recently the salaries for family doctors, and especially rural family doctors, are now higher than the salaries for specialists. So that's helping some, but all the salaries are too low to make a huge difference.
Dr. Anshu?
I don't know whether this is a solution, but one problem which people face is we don't view rural physicians with that prestige, that respect that we view people living in the cities. So that if in some way we can change that and treat people who serve in the where they're needed most with more respect, probably the peer pressure will be can be reversed. I don't know how we are going to you know uh, praise those kind of those people who go there, or give them some kind of recognition, that should work.
Yeah. But I think that the rural physicians, those who are working there, they get lots of respect from the rural people. But whereas I see that urban doctors may not get that much of respect from the urban counterparts, but rural doctors are
No, but
usually treated
if
like a
they
god.
compare themselves with their peers,
Yeah.
that there is always that kind of mental block that they are earning more, they are living in a more uh in a place which is more easier for life. So
Yeah.
that recognition is never given. At least in our country, it's not given.
Okay. Yukti, your final comments on the solutions.
So we have been having this parallel conversation in the chats as well. So what I think is it's not just one aspect that would help retention of doctors in rural areas. We would have to attack this problem from multiple areas, not just giving high remuneration, but also providing, a safe place to live at, a comfortable house, proper sanitation, proper services, proper roadways, availability of drugs in the area, because pharmacies is also lacking in a lot of rural areas. Like in rural areas, sometimes people have to travel like 5 kilometers just to get to a pharmacy. So, getting all the services in the area would probably help, more retention in some of the rural areas if we have all the facilities available around. So, because one of the problems that doctors also face is you write the medicines, but the patients can't afford to buy them, or they cannot actually get to the facility to get them. So if they have all those facilities nearby, probably they will feel more satisfied with their jobs as well. And obviously, a higher pay, I think, would help them, moving to a rural area, your cost of living is lower, and then you're earning higher, your savings are better. People would probably at least work for 5 to 7 years then.
Right. Because question?
Yes, Pratyush.
Okay. The final comments.
Yeah, thank you. Thank you so much, everyone, for your inputs. Hopefully, we'll be making the manuscript more readable in the next 1 or 2 weeks, and hopefully, we'll be able to publish something from this meeting as well, from all of your inputs. Thank you, Pratyush, for your leadership.
Thank you. Thank you. Izaz Khan, your final comments on the
Yeah.
solutions?
Yeah, I think we should be looking at Iran's model because they have like someone was talking about the Kyrgyzstan model as well. So I think these we should also look at these models, how they are doing it, and in very resource constrained kind of things. So we are better off if you see the other countries. So economically we are perhaps better off them, but they have the processes which are helping their healthcare force
Right.
retaining their healthcare force and also improving their indicators. So their rural indicators are far better than us, the health indicators. So this is the two prongs. It should be a two-pronged strategy. One, how to retain our healthcare force in the rural areas, and secondly, how to improve the health indicators of the rural areas, because that's also very much required, because our countries are seeing rapid urbanization. So rural areas are becoming urban. So that's need to be considered. Yeah, thank you.
Thank you. Aitrick Das.
Yeah. So I'm slightly of the opinion that not just in India, but I think even in our neighboring countries, it is difficult to expect, and it is rather unfair to expect that the doctors will be retained in the rural areas, or we'll have foolproof strategies like living conditions and facilities to, like, for example, someone mentioned schools. So for that in the rural areas on a long-term basis. So the strategies that we have been employing over the years, like developing cadres of workers who from these areas itself, for like the health workforce also includes the community health workers. It also includes the technically the Anganwadi workers. It also after a certain point, right now it includes the CHOs, the community health officers as well. So maybe the alternative is to focus on a rigorous training curriculum for these workers, which rather standardizes the form of care that they receive, that they can provide, and then refer onwards to the at least the primary health center where we have the first doctor. So maybe that is the other way around, that we actually go around strengthening our grassroots level healthcare, as opposed to trying to ensure that our doctors go and stay in the rural areas. We could approach it from both ways, but I think the downwards to upwards mechanism would work easier. So maybe that is the way forward.
Thank you. Thank you. Anyone else would like to give their final comments before I end this webinar? And
Yes.
please go ahead. Yeah.
Yeah. Thanks everybody for the progress in their country. In Nigeria, we have problem. The doctors cannot stay in the rural area because of poor security. And also most of our young doctors now go to the Western world to practice. So because of the poor infrastructures around the country. So improvement in rural infrastructure can help in retaining doctors in the rural area. And I'll praise the effort of those countries that give more incentives with their doctors in the rural area. I hope this can be replicated in the other part of the world to improve the rural healthcare. Thank you.
Thank you. Anyone else would like to give their final comments? So thanks a lot, everyone, for joining this webinar. It was really very nice listening from you, the perspective, your context, and how the workforce strategies have worked in your areas. And we will include all your suggestions, your feedbacks into our manuscript. And hopefully, we'd love to see you during our conference, the Global Rural Health Summit in Bengaluru. If you can come, it would be great. And anyway, we'd like to welcome you to another webinar, which we'll host in another 2 weeks' time. I'll send you the details. And those who couldn't attend this webinar, I'll send you the link of the recording so that you can have a rewatch. Thanks a lot. Thanks for joining. Have a great day. Thank you.
Thank you, everyone.